We hope this afternoon will bring about questions and answers, and we can walk away with a call to action. A call to action on how working with our partners, PHRMa, thank you so much for bringing this information to our legislators, for being one of our strong supporters to help ensure that our legislators have the information, as I say, the tools in the toolbox to handle those things that they need to do the people's work. We welcome you. If there are any questions that you have during any of the presentations, please put your questions in the chat. We hope to have a lively discussion once all of our presenters has presented. And now I'd like to turn it over to our president, the one and only Representative Billy Mitchell from the great state of Georgia.
Thank you so much, Paula. I do appreciate it. And I do appreciate all those of you who are participating as well as viewing this webinar. I think it's of immense importance to the legislative work that we do across this nation. Let me just take this special opportunity to thank PHRMa for being a part of this, to making sure that they spearhead the information that we're receiving. You know, PHRMa is just not only a supporter, a participant, but they truly are a partner. Healthcare is one of the most important issues that we as legislators face in our legislative chambers in this nation. And I will tell you, is this kind of information that we need, that we have to take back to our communities so that we can be better legislators and certainly have healthier communities. So thank you very much, PHRMa. Representing PHRMa, I'd like to bring on at this time, Courtney Christian, take it away. And once again, I thank you for being a partner with the National Black Caucus of State Legislators. This is invaluable to us, and I want you to know that we appreciate it.
Thank you so much for that wonderful introduction, Mr. Mitchell. You know, we're trying very hard at PHRMa to live up to the praise that you've given us, and we've very much enjoyed the partnership that we've had with NBCSL, certainly in participation in the annual conferences and in the committee settings in which you all have meetings to discuss different issues, especially healthcare, which is, you know, what we are all about at PHRMa. So thank you so much for that. And if you give me just a moment, I'm going to share my screen. I am Courtney Christian. I'm a senior director at PHRMa. I focus on state-based reforms impacting health insurance and prescription drug coverage and public health programs. I work on health equity, and I lead our equity initiatives at PHRMa. Prior to joining the organization, I was director of policy and advocacy at the Black Women's Health Imperative, and I worked on Capitol Hill for a number of years, culminating as a legislative director. For all my Florida representatives, I'm a Florida State University alumni and football fan, an aspiring chef, and a mom to an energetic kindergartner. I just wanted to start our conversation with you all today, sharing, you know, sort of what we are espousing at PHRMa in terms of our leadership. Our first ever chairman of the board, who is a woman. She is the president of Takeda, Ramona Sequeira. And she has really given us a charge, our entire board really has, to think about how we can be better partners in communities of color, what our specific and unique niche could be in bridging healthcare gaps, and coming to the table to bring our research and our resources to address health equity. We recognize, of course, that many factors drive health inequities. And as we thought, particularly in 2020, when we saw the confluence of COVID-19 and just all the social justice issues bubbling to the surface, you know, how can we, again, be better partners in communities of color? So we really committed ourselves to some racial justice principles and started out with a very bold statement that guides that work. And that is that systemic racism is as real as any disease, and our industry is not immune. You see here my small, energetic, then 4-year-old who I drug out in the middle of the morning to find this ad everywhere. But I use this picture a lot because I draw the parallel to him and what the work that I hope that I'm doing at PHRMa will be meaningful for him and for future generations, but also in the very present, right? And that includes having these open and honest conversations about racial equity and what it means to have a culture of inclusion, thinking about how as an industry we can expand opportunities to work and succeed within it. How can we advance policy solutions? And this is where we'll lean on you all in research to better address health disparities. How can we diversify our business practices to better invest in underserved communities? And then how do we really, and this is key, earn trust to really address those systemic issues that underserved communities find when they want to participate in clinical trials, which is a specific industry niche for us, so that people who want to participate can. Out of that was born the PHRMa Equity Initiative, and it was really created to build necessary, positive, and long-term systemic change. And it centers around 3 key pillars around clinical trial diversity. So how can we design a community-based clinical trial infrastructure so that patients who want to participate can? In terms of health equity, how can we work towards addressing a health system and addressing social determinants of health that impact health inequities? And then on talent, how do we support growth in a diverse industry talent pool? When we double click on health equity, we made a commitment to building a better healthcare system. And again, addressing those health system and social determinants of health that impact health inequities. And there's a very good question about what makes us healthy. And all these social determinants that you see here on this slide do that. Our family, transportation, our environment that we live in, our level of education, our income, where we live, what we eat, all impacts that whole person there in the middle. This slide, I think, really gets to what you'll hear more from Milena and from my colleague, Cynthia Hicks. And that is sort of the barriers that folks face when they go to the doctor, and the feelings that they take into the room with them when they're meeting with their doctor. A recent study showed that a wide swath of patients of color feel discriminated against when they're seeking healthcare due to their race or to their ethnicity. And you see the numbers here. And a lot of that is undergirded by implicit biases in the system, right? That subconscious bias, those subconscious attitudes and stereotypes that affect anyone's understanding, including your doctor. And they come out in an unconscious manner. And so we see a lot in the literature more and more that implicit bias really does contribute to inequities in patients' receipt of medicines and other healthcare. When we're thinking about health equity at PHRMa, we're thinking about disparities in medicine use and access at every step of the process. And you see here on the left, we're thinking about what does it mean to have appropriate medicine access and use, and what are the elements along the way, researching clinical trials, the lack of diversity in researchers and investigators, thinking again about those social determinants of health that are so key and that drive everything, access to healthcare, lack of insurance, quality care and receiving the needed prescriptions, insurance access barriers you'll hear a lot more about, and benefit design. Do people understand what those terms mean and how they apply to them when they have health insurance? And other barriers, other cultural norms, or other things that might affect lower adherence rates. And on the right side of the screen, you'll see how we're really digging in on that research and adding our voice and our resources around that, thinking about benefit design in conjunction with the AMCP. We wrote a comment letter to the newly formed Congressional Caucus on Social Determinants of Health, thinking about how we understand why people abandon their medicine and how that can be a barrier to health equity. Thinking a lot, as we heard during the height of the pandemic, about data collection, right, around who has COVID and who doesn't, and really trying to get a handle on the sorts of data that we needed to be able to make a dent in who and how COVID was treated. And then thinking too about enhancing clinical trial diversity. When diverse populations participate in clinical trials, that can have a downstream effect on closing healthcare gaps on the other end of the trial. A marquee program that we've had in the states, and we've had some and probably in a lot of you all states here, is our CARES grant program. And the CARES stands for Collaborative Actions to Reach Equity. And here we're really trying to advance access through community-driven best practices and solve for small community-based problems that could be scalable or replicable elsewhere. And so you heard me talk about implicit bias. We funded a grant through Xavier University and the Louisiana American Academy of Pediatrics on that. We're looking at racial disparities in medication utilization and adherence. We did a lot around COVID-19 uptake, vaccine uptake, and thinking about chronic diseases that disproportionately affect our community, like hypertension. And so I encourage you to follow our progress on pharma.org/equity to learn more about this program and other work that we're doing. And lastly, I think the big question is here before I turn it over to Milena, is to think as you hear all of our presentations about what you can do. It takes a village, right? There's that old axiom that it takes a village. And I would posit to you all that, you know, you all understand the lived experiences of your constituents more than anyone else. And you probably hear every day the barriers to healthcare that they face. That you're thinking about as you're in your state legislatures in session. How do you provide resources to help constituents navigate the healthcare system? What policies are best to address those social determinants of health that are so key to health outcomes? And then how you might be strategic in your own ways in your own state in leveraging state, county, federal, and private resources for this effort. So with that, I'll turn it back over to Paula. Thank you.
Thank you so much. Thank you so much. You've given us a wealth of information, and I want to just put a little tickler in our legislators' mind right now as they think about this conversation that we continue to go through over the next hour. Particularly the last slide that you went over. Understanding what's going on in the system, providing information, enacting policies. And when we enact the policies, how are we as legislators being strategic to ensure that this information is getting to your constituents? Just think about that, and then maybe when we get to the end, we can discuss how, as I said, I wanted this to be something like a call to action. How do we move forward? How do we move forward with this to ensure? So our next presenter will just go a little bit deeper and talk about how we're going to do this, the role of the legislator, and what are our outcomes.
Hello, everyone. My name is Milena Berhana, and I am from the National Consumers League. First, I would like to thank NCBSL and PHRMa for inviting me to speak with you all today. And so today we'll be discussing aspects of healthcare plans that are important to understand when choosing a healthcare plan and navigating health insurance. So in our discussion today, we'll be discussing the following. We're going to talk about the types of insurance plans, key terms to be familiar with when choosing a health plan, and different aspects of plans that a consumer should look for when choosing or avoiding certain health plans. I do want to preface this presentation and say that these slides will be circulated afterwards, so you have all this information for reference because it is a lot of information. So we'll start with in-network and out-of-network providers. So the main difference between the two is whether or not a healthcare provider or plan contracts with a health insurance plan to provide services at a pre-negotiated rate. So if a provider is in-network, it's going to be lower cost sharing for patients, meaning they're going to be paying less money for their healthcare services, versus if they visit an out-of-network provider, the cost will be higher. So when we look at the different types of health insurance plans, first we have a health maintenance organization, also known as a HMO. These plans work strictly within their network and limit the types of healthcare providers a patient can see. So in the case that a patient needs to see a specialist, a HMO plan makes sure that the patient has to see a primary care physician first, which is also known as a gatekeeper, beforehand in order to be referred to the specialist. Another type of plan that provides more flexibility in choosing providers for patients is the preferred provider organization plan, which is also known as a PPO. Patients with PPO plans do not need the approval of a primary care physician, unlike the HMO, which does, and services can be covered if they are provided by out-of-network specialists. The third type of plan is a high deductible health plan, which has lower monthly premium payments. However, for this plan, the out-of-pocket cost the patient has to pay before insurance kicks in, which is also known as a deductible, will be higher. So these plans are more popular with younger patient populations and people who do not anticipate to need as many healthcare services, so they don't anticipate as many out-of-pocket costs for their deductible during the year. And lastly, we have a health savings account, or HSA, which is similar to a personal savings account where a person can put aside pre-tax dollars to put towards their healthcare services. And they also have control over how they spend that money. And a health savings account can only be paired with a high deductible health plan. So now we're going to review some key terms to know when understanding the different aspects of a healthcare plan. So firstly, we have a premium, and the premium is what a consumer pays for their health insurance plan every month. And this is a monthly rate set by the health plan, and the cost will differ based on the type of plan that a patient enrolls in. So for some context, we have an example here. If a patient is looking through different plans and ends up choosing a plan with a monthly premium of $175 per month, in order to maintain that health coverage from that plan, they will be required to pay that $175 per month. And you can kind of think of that as like the rent you pay to stay on a health insurance plan. So another cost that a consumer has to take into consideration is their deductible, which is the amount that a person has to pay out of pocket before their insurance starts to cover their services. So for example, if you have a $1,000 deductible and you have not paid any of your deductible yet, you visit the doctor's office, which costs the patient $100. So therefore, the patient will pay $100 out of pocket for that visit, which goes towards their deductible balance. And then after paying that, their deductible balance is $900. So the patient will keep paying off until that $900 is paid, and then insurance will begin to kick in and pay for the services afterwards. So for coinsurance, after paying off your deductible, the insurance will still not pay the entirety of your health services. There is coinsurance, which is the percentage of healthcare costs that a consumer pays after meeting their deductible amount. So let's say you've met your $1,000 deductible and your coinsurance is 20%. So you will pay 20% of any healthcare services that you utilize after meeting that $1,000 deductible. So therefore, if you visit the doctor and the bill is $100, you will pay 20% of that $100, which is $20, and your insurance will pay the remaining $80 balance. Another cost to consider for patients is a copay, which is a fixed amount that you pay for various medical services after meeting your deductible. So copays differ based on the types of services you receive. So let's say you've met your $1,000 deductible, if we're running with the same example. And your copay for each primary care physician visit will be $25. Your copay for an ER visit will be $250, and so on and so forth for other different types of services. And the copay amounts do not change throughout the entire year because it is a fixed price, and your insurance plan will set that price for you. Lastly, we'll discuss an out-of-pocket maximum, which is the total amount of money that a patient pays out of pocket for all healthcare services and medications during the year. So however, this out-of-pocket maximum does exclude your premium. So the monthly premium you will pay regardless, and then the out-of-pocket maximum is any other out-of-pocket cost that a patient pays outside of that premium. So after hitting that out-of-pocket maximum for the year, your insurance plan will pay any other costs for the rest of the year. So if we're running with the same example we've been using, let's say a patient's out-of-pocket maximum is $5,000. Your premium is $300 a month, your deductible is $2,000, and your coinsurance is 30%. So the monthly $300 premium you will pay regardless of any other costs. You will pay off your $2,000 deductible out of pocket, which goes towards your $5,000 out-of-pocket maximum. So your deductible does count towards your out-of-pocket maximum. So now your out-of-pocket balance after paying off that deductible will be $3,000. And because you've met that deductible, the $3,000 remaining balance you have will include the 30% coinsurance. This means that you're not only paying for every service out of pocket on your own like you would with the deductible, you're only paying 30% of each service since you've already met the deductible. So when you end up paying the $3,000 with your coinsurance included in that, your insurance plan will then pay any other costs for the remainder of the plan year. This is just a visual showing what we discussed. Okay. And now we will discuss other aspects of health insurance plans, including types of plans, benefits covered, and so on. So there are different metal levels which determine how much a patient will pay and how much the insurance plan will pay. If the consumer pays a higher premium or higher monthly cost, they will pay less out-of-pocket costs when they are receiving care. And vice versa, for those with lower monthly premiums, they will pay more out-of-pocket when receiving care. So this is just showing you that platinum plans have a higher monthly cost, but the patient cost when they get the service will be lower versus a bronze plan, which has the lowest monthly premium cost, but will cost the most when you do go to get those healthcare services. And this is just another visual of that, showing a graphic of how much the consumer will pay versus how much an insurance plan will pay. And so there are also tax credits that you can get to lower your monthly premium, which is known as an advanced premium tax credit or subsidy. So these credits were created for people of low to moderate income, and the lower the income, the greater the tax credit. So the way a person can get this tax credit is by including their estimated income for the upcoming year in healthcare.gov, which is also known as the health insurance marketplace. And this is where you go to get a marketplace insurance plan. So if you are eligible for a tax credit, you can apply it to lower your premium for the upcoming year. And this can be applied on any metal level plan. So whether you have a bronze plan, platinum plan, silver plan, or gold plan, if you are eligible for these tax credits, you are able to apply them to lower your premium. Another means of reducing health insurance costs is a cost sharing reduction, which is a discount that lowers consumer cost sharing. So that includes lowering your deductible cost, co-payment cost, and co-insurance cost. So there are also eligibility requirements for this discount, which is also based on income, similar to the tax credit. However, you must be enrolled in a silver level plan to apply a cost sharing reduction discount. And if you are eligible for a cost sharing reduction discount, you will also pay less out of pocket, giving you a lower out of pocket maximum. So there are 10 categories of health services that the Affordable Care Act, or the ACA, requires individuals and small group plans to cover. So these essential health benefits include emergency services, outpatient ambulatory services, preventive and wellness services, maternity and newborn care, pediatric services, hospital services, various therapy services, prescription drugs, lab services, and mental health or substance abuse services. So large plans that cover more than 50 people are not required to cover these services under the ACA, and dental services are required to be covered for children, but not for adults. And a health insurance plan that does provide all of the essential health benefits that are covered under the ACA are called qualified health plans. So these plans are certified by the health insurance marketplace and are deemed to meet all of the requirements for health coverage under the ACA. So now we're going to discuss what consumers should consider when choosing a health plan to fit their needs. So when looking at plans in the individual marketplace, it's important to know that coverage does get better as you go up the metal levels that we discussed. So as a reminder, the plans go from bronze with the least coverage to silver to gold to platinum, which has the best coverage. And in order to utilize cost sharing reduction discounts, if you are eligible for them, you do have to have a silver plan. So for the majority of people who do not pay the full premium of their plans because of these subsidies and discounts, for example, people up to 150% of the poverty level can get premium-free silver plans with no cost sharing, meaning they do not have to pay any of the out-of-pocket costs for their healthcare services because of those discounts being applied to their plan. And just for reference, the average marketplace plan premium in Alabama is $795 per month, but with a subsidy applied, it is $96 a month, which can be a significant reduction in cost for consumers. And there are also things to consider when being enrolled in an employer-sponsored insurance plan, which many people do get health insurance coverage through their employer. So similar to marketplace plans, employer-based plans with lower premiums will have less coverage. So it's very important to compare the cost of premiums for a plan with you and your family's health needs. So if you're looking at a plan with lower premiums that may look more attractive because it's a lower monthly cost, it's important to consider any anticipated healthcare service use. So if you're going to end up needing more provider visits, medication costs, or any other healthcare costs, you might end up paying more on copays and your deductible and through your out-of-pocket maximum because you are paying a lower premium, which can then outweigh the benefit of paying that lower monthly premium. And in addition, if you're looking at a high deductible health plan, it's important to see whether or not HSA is available and whether your employer contributes to it so it can lower your out-of-pocket costs. And so now we'll discuss what to look out for and what to avoid when choosing a health plan. So we're going to review the following additional key terms to know when looking at health insurance plans. And one important term to know is a formulary. So the formulary is a list of prescription drugs that is covered by an insurance plan. So formularies typically list drugs on tiers, and the number of tiers will depend on the specific plan. So as the tier number goes up, the cost of the drug for the patient will also go up. And as you can see on that image on the slide, generics, which tend to be lower in price for patients, are on the lower tiers on 1 and 2, while specialty drugs, which are more costly, are on the higher tiers, which can go up to 5 or 6. And it's important for patients to consider which drugs they'll need and their health condition needs and seeing whether a plan will cover it and what tier it's on so they'll know for their own cost information. A formulary exclusion list will include which drugs a plan or pharmacy benefit manager will not cover. So pharmacy benefit managers, who are also known as PBMs, are middlemen companies that work with health insurance companies to oversee prescription drug plans. So these PBMs set the formularies, they can set patient copay amounts, pharmacy networks, pharmacy reimbursement rates, and the rates charged to plan sponsors. So over time, formulary exclusion lists have been getting longer, which means that patients have not been able to get covered for as many drugs as they used to. So for reference, in 2020, the 3 largest PBMs have excluded 846 drugs from their formularies, compared to only excluding 109 in 2014. So another thing to know is prior authorization, also known as prior approval, which is the process where a health plan requires healthcare providers to seek approval in order to cover payment for services or for prescription drugs. So pharmacy benefit managers, or PBMs, use prior authorization to restrict access to certain services and drugs, either because they don't think it's worth paying the amount for it, or they want the patient to pay more for the more expensive option. So the prior authorization process can also be lengthy, which harms patients in the long run by preventing them from getting the services and treatments they need when they need it. Another thing is step therapy, which is also known as fail first. And this is a requirement that was put in place by health insurers as a means to contain cost. So basically, more cost-effective or inexpensive drugs and therapies have to be tried first before a more expensive alternative in order to be covered. So this can also be very harmful to patients for a number of reasons, including more time spent trying to be treated for their condition by using the less effective one first and having to fail first, as the term says. Also, the possibility of additional adverse health events and more out-of-pocket costs from having to try one first and then having to maybe find the one that works for them in the long run. So utilization management basically describes the different techniques that health plans use to evaluate efficiency, appropriateness, and medical necessity of the treatments, services, procedures, and facilities that a patient will utilize. This includes the ones we've just reviewed, including prior authorization and step therapy or fail first. And utilization management can restrict patient access to services and drugs that they may need because of the additional burden of needing approval. So plans that have or utilize more utilization management techniques can also be very, very harmful for patients in the long run. So health plans utilize utilization management practices to contain costs, but as I said, this restricts patient access to health services, treatments, and prescription drugs. So formularies are also discriminatory used. While there have been instances of plans putting all of the needed medications for certain diseases on higher tiers, which means they're more costly for patients that may be dealing with that disease or condition. So this is why it is critical that patients look at formularies and take into consideration their health needs before enrolling into any specific plan. And there are some rules that have been put into place to combat this issue, but patients should still be on the lookout anyways when determining which plan they want to enroll in. So copay accumulator adjustment programs can also add costs for patients. So these programs do not count the value of copay assistance towards your out-of-pocket responsibility. So once the copay assistance runs out, which can be in the form of a coupon or discount from any pharmaceutical company, the patient will then have high unexpected out-of-pocket costs for the rest of the year. So there is language that patients can look out for, which includes the following example, where a plan will tell you that cost sharing reduction through a discount from a drug manufacturer will not apply towards a deductible or annual out-of-pocket maximums. So if you see that language when looking through health plans, it's important to know that this may result in higher out-of-pocket costs. Another thing that patients should be on the lookout for is the essential health benefits loophole. And so the essential health benefits are the 10 categories of essential healthcare services that small and individual plans are required to cover under the Affordable Care Act. And so some health plans have attempted to go around this by defining some prescription drugs as non-essential, although they are required to cover them. So this translates to more out-of-pocket costs for the patient, which does not go towards their deductible or out-of-pocket maximum. And so this loophole can also be found in a health plan's description with wording like this example, which states that specialty medications are not considered under the 10 essential health benefits, when in reality, there is the possibility that those specialty medications should be covered as required by the ACA. And so that is my high-level overview of health insurance. Thank you all for your time. And here's my contact info if needed. So thank you.
Thank you, Melina. And just as real quickly, a takeaway from her presentation and to remind everyone that all of the slides will be provided to you, so you don't have to worry about trying to take all these notes to keep up with everything that was said. In-network, it's important to know, in-network, out-of-network, your deductible, copay, out-of-pocket, and tax credits are just a few of the takeaways that I wanted to put in the forefront of your mind of how you need to understand this information to help others navigate the insurance industry. Thank you so much for that. And now we'll hear from Cynthia Hicks. Cynthia's going to give us at a high level the results of a survey that I think you'll find astonishing, and how this survey depicts how your constituents, how they're treated, how they're managed, and how things are done in the healthcare field. So Cynthia, turn it over to you.
Thank you, Paula, and thank you everyone on the call. I really appreciate the opportunity to talk a little bit about our patient experience survey that we ran at PHRMa just very recently. So I'm gonna just go ahead and share my screen really quickly, and then we can dive right in. Okay, perfect. So the patient experience survey was a thought leadership series that we began at PHRMa last year. I believe it was last fall. And really the reasoning for it was to really unpack the patient experience and really kind of drill in and understand what are the perceptions. Like, we have a lot of data sets, there's a ton of data and reports out there, but we really wanted to have a channel where we can hear from Americans, real patients out there, to really pinpoint what are the specific affordability challenges folks face and what are some of the hurdles that they face. So this is a survey of 5,000 Americans that we do, and we run it about 3 times a year. We're actually working on our 3rd wave right now as we speak. And of those 5,000 Americans, that sample size really allows us to slice and dice the data and really narrow in on specific patient populations that we'll talk about a little bit more in this presentation. But first, here are just a couple of key headlines and takeaways from our latest report, where we titled it "Covered but Still Exposed." So it really is a report that talks to all of the Americans who are covered with insurance. So these are insured Americans, but still face vulnerabilities when it comes to affording and accessing their care. So if you look at it and how we did it in the report when we did the analysis, was we looked through 2 different lenses of barriers to access and care that we saw. First, there were the financial barriers to care. So here, number 1 takeaway, we found that more than 1/3 of insured Americans face significant financial barriers to care, such as unaffordable out-of-pocket costs. So we'll drill into that, but more than 1/3 of folks who are insured still can't afford their care, which we found very astonishing. Secondly, 41% of those who struggle with out-of-pocket costs, they cite deductibles as the main cause of their out-of-pocket burden. So as we just saw in the previous presentation, out-of-pocket costs are costs that folks have to pay at the pharmacy counter, really out of pocket. And folks really struggle with that. Folks struggle with affording their deductibles. Number 3, we found that half of prescription drug patients experience insurance barriers, like we just learned about, utilization management barriers such as prior authorization and fail first. So again, this is a survey, so this is all self-reported data, but we found it really eye-opening that half of folks who are receiving prescription drugs are really facing at least one of these barriers to care. And then finally, when looking at insurance barriers in particular, we found that this disproportionately affects communities of color, Black and Hispanic Americans, those with chronic illnesses. So the discrepancies are pretty vast when we kind of look and compare and contrast. So we'll dig into that in the presentation as well. So firstly, just wanted to really highlight that first point that I mentioned. Within our survey, we found 37% of insured Americans face some sort of financial barrier to care. And if I could really underscore the headline here, is that when we looked into this 37% population, we found that they were disproportionately women, they lived in urban areas, and they had less formal education. So again, these are constituents who are insured and are still having a hard time affording their care. So if we want to look at the right-hand table, that kind of gives you at a glance how we came up with this 37% number. It's folks who had difficulty affording their out-of-pocket expenses. They had no savings that they could immediately access for emergency or unforeseen expenses. And they reported spending more in out-of-pocket expenses than they could afford in the last month. So kind of all of these things put together made up this 37%. And again, what we found most eye-opening were kind of the profile of those who fit into this category. We found that besides women and those in urban areas with less formal education. Many of them had chronic conditions and already reported poor health. So what we found was that those insured Americans who had financial barriers to care often were those who really needed the care the most. So we also wanted to look at the financial barriers and look at the data across the different racial and ethnic groups to see if there were any changes or differences to note. And what we found out here in this chart, you can see that unaffordable out-of-pocket costs required by insurance disproportionately burden Black and Hispanic Americans. So if you want to look at this blue bar right here up top, that's all insured Americans overall. 19% of them say that their out-of-pocket costs are more than they can afford. If you look towards Hispanic and Black Americans, that percentage increases, it ticks up a little bit. So we did want to note that, and we'll see even larger gaps and larger discrepancies as we go into other insurance barriers. Besides looking at the racial and ethnic groups, we also wanted to look at patients with chronic illnesses to see kind of how they fared with this out-of-pocket question that we posed in our survey. And so again, you can see that all insured Americans, 19% of them said that their out-of-pocket costs are more than they could afford. That increases pretty significantly when you look at specific patient populations, like those with autoimmune diseases, mental health conditions. That number ticks up to 29%. And those with neurological conditions, that number ticks to 33%. So again, we're seeing that across communities of color and across patient groups and populations like those with chronic illnesses, they're really feeling the burdens in a way, in a disproportionately high way. So that's something that we did want to point out when it came to some of the financial barriers to care. We also found in our survey that insurance is not protecting all Americans from medical debt. So one could expect that, if I'm paying insurance, if I'm paying my monthly premium, that should help. That should not saddle me with medical debt. But in our case, we found that even if you do have insurance, many Americans still face problems with medical debt. So as you can see here to the left, 27% of insured Americans have outstanding medical debt with an average debt of $4,000, which again, may not be the expectation we might have if we're making our payments and having insurance. When we look at medical debt by race, we see that these numbers again tick up when we look at Black Americans and Hispanic Americans. So whereas white Americans, about 26% of them have medical debt, that number ticks up to 33%, and then 36% among Hispanic Americans with medical debt. So again, we're kind of seeing how the barriers are even more exacerbated among these different groups. Next, besides the financial barriers to care, something that we looked at within our survey and our report were other insurance barriers to access and care that we talked about a little bit in the last presentation. But practices like prior authorization, step therapy, fail first, exclusion, from a formulary, all of those practices, we find in our survey that they disproportionately impact Black and Hispanic Americans. So as you can see on the chart, when we ask folks if they've experienced at least one of these insurance barriers, so how we had it worded in the survey, we asked a question and we didn't say the exact terminology, but instead we said, I had to wait for my insurer to provide prior authorization for a medicine my doctor prescribed, or I had to try and fail on another medicine before getting the medicine my doctor originally prescribed. So we asked a series of different questions about barriers and if folks have experienced that in the past 3 months. So all of the data that you see here are respondents who said that yes, they have experienced at least one of these practices in the past 3 months. So pretty high number, 49% overall among all RX patients said that they have experienced at least one of these in the past 3 months. So just that sheer number who have experienced these types of hurdles was really eye-opening for us. And then if you look across, we see that among white Americans, that number is 44%, Black Americans, 55%, and then Hispanic Americans, that number, that experience with utilization management and these barriers climbs up to 64%, which is significantly higher. And we definitely wanted to make sure to kind of highlight that and the barriers to care that these groups are facing. On the flip side, when looking at Americans with chronic illnesses, we see a similar pattern. So again, overall, when we're looking at the entire population of RX patients, that number is 49% who have experienced at least one type of insurance barrier. That number climbs when we're looking at folks with chronic illnesses. I did want to highlight mental health conditions, that number going to 65%, and then 73% with for patients with autoimmune diseases. So again, a lot of these insurer-imposed barriers to care are not only hindering care for, insured patients overall, but when you drill deeper, it really impacts the patients who need care the most, those that are already most vulnerable. So we definitely wanted to highlight that, those findings, and really shed light on that when it came to some of the findings in our report. So those were the major key takeaways from our PES survey. Again, it was released very recently. If you have any questions, we are sharing all of the slides. So you'll have these slides available to you, as well as a couple of handouts and pieces of collateral from the survey for you all to share. And all of this data is public on our PHRMa website. So I encourage you all to take a look at the larger report, as well as some of the collateral pieces that dig into a little bit more detail on some of the topics that we talked about today. So with that, I think I will pass it over for our Q&A section.
Thank you, Cynthia. I'm not even sure where to start with this. When you look at the information that you just presented at a high level on the survey, and I love your title, Covered but Still Exposed. When we look at 49% of those who are covered are still experiencing issues. So the call to action, what information or how do our legislators work with you, work with the industry to ensure that we bring that 49% down? When we look at what we've just gone through with COVID and the health disparities that has risen its head to show the disparities in communities of color, but then we look at the numbers of those that are impacted, how do we as legislators work with these issues to ensure that good policy is developed, to ensure that those who are covered to where it benefits them? When you look at women, you said 30 women in urban areas, and we know that women are the caregivers. So if they are not getting the coverage that they need, which brings on chronic illness, then it just keeps the cycle going on and on. So I want to remind everyone, if you have questions, put your questions in the chat. Otherwise, we will use this as building our foundation, building the foundation with NBCSL and our corporate partners to move through this issue from state to state, how do we create good policy to ensure that those who are insured receive the care, the service that they need from the insurance companies? Those who are underinsured are not facing those issues that are put before them that has been presented to us today. If there are no questions, we will say thank you. Thank you for joining us this afternoon. We hope this information has been beneficial. As I said, the information will be provided to you so that if you review it and at a later date that you have some information for the folks at PHRMa, then we will get that information back to you. Again, thank you so much for joining. Thank you, PHRMa, for bringing this information to us, and let us use this as a call to action to move forward to ensure that we provide good policy for your constituents. With that, I'll say goodbye.